thought I saw Angela come on. Well, if Angela pops on later. Tamara's joining. So I'd like to welcome Rachel today to our Pink Task Force call. And Rachel, take it away.
Great. Thank you, Catherine. Thank you for the invitation. I'm really excited to be here. I think I'll just share my screen and make sure that's all going to work okay. Let's see here. Oh, can everyone see? Okay. Great. So I can't see you while I'm presenting. So if someone has a question, I think because this is a smallerish group, it'd be great to, you can just feel free to interrupt and let me know if something's not clear when I'm speaking. Catherine asked me to introduce myself. My name is Rachel Sayko Adams. I'm a health services researcher with public health training at Brandeis University up near Boston. I work at the Institute for Behavioral Health there at the Heller School for Social Policy and Management. I do have an appointment at the Veterans Health Administration with a group in Colorado doing suicide prevention research. Today I'm going to speak about at-risk substance use following traumatic brain injury and conclude the talk with an area that's really something I've been thinking about for a couple years, but don't have expertise in necessarily or prior research in this area, but thinking about how the intersection of TBI and substance use may relate with intimate partner violence. So that's an area I hope to talk more about with you and engage in a conversation towards the end. On a second. Okay. All right, so today I'm going to talk about some research findings from a variety of different grants of ours at Brandeis. One of them is our Inroads study, which stands for Intersecting Research on Disability and Addiction, Opioid Misuse, Addiction, and Disability Services. That's funded by NIDLR. Obviously what I'm presenting today are my own views and that of my co-authors and do not represent the institutes I'm speaking about. Okay, so I'm going to speak about the relationship between TBI and post-injury substance use. I'm going to go really in depth with this more recent work I've been doing with colleagues John Corrigan and Kristen Dams-O'Connor on the theory of the perfect storm, increasing risk for opioid use and adverse consequences following TBI. This theory is supported by prior research findings on alcohol use and other substances. I'm going to talk about findings from both military and veteran populations as well as civilian studies, but more of my work has been with military and veteran populations. So you'll see a lot of that in the talk today. And then I'll conclude with a brief conversation about how intimate partner violence may relate to this intersection. Okay. Okay, so this graphic is from an issue brief that we developed for our Inroads project at Brandeis. Here we show, we created this to be targeted to substance use treatment providers to show that history of TBI is common among persons that they're seeing. So we know that 1 in 5 non-institutionalized adults has experienced at least one TBI with a loss of consciousness in their lifetime. And estimates of TBI are at least double among those with a substance use disorder, and they may be even higher among people with both substance use disorder and mental illness. Substance use is a risk factor for TBI. Persons with a history of TBI are more likely to have pre-injury substance use problems. And studies show that between 1/3 to a half of individuals are intoxicated at the time of their injury that led to the TBI. After injury, many individuals do reduce or stop their drinking for a period of time, yet many do resume pre-TBI drinking levels at 1 to 2 years later, or even increase drinking levels. Substance use following a TBI may reduce brain healing, impede rehabilitation, and increase the risk for future injury, future TBIs. And there is growing evidence that experiencing a TBI during childhood specifically may increase risk for substance use problems in late adolescence or early adulthood. So we have some publications on our team in the area of opioid use following TBI. And the first commentary we wrote in Addictive Behaviors was really targeting substance use treatment providers to help them think about why it's important to understand history of TBI in their practice, and also why people with TBI may be more likely to have an opioid use disorder and require accommodations for successful substance use disorder treatment. Next, we published a commentary in Journal of Neurotrauma, which synthesizes what is currently known about risk for opioid misuse and opioid use disorder following TBI, and why we think persons with TBI may be uniquely vulnerable to these problems. I'll go over the main points of this theory today in my talk. And lastly, we have these 2 issue briefs, which summarize these commentaries, as well as other issue briefs from the study, which are available on our Brandeis website. The link is here. And I encourage you to read them and disseminate and share them broadly. So this slide provides an overview of the conceptual model supporting the potential perfect storm facing individuals with a history of TBI. In summary, Drs. Corrigan and Dams O'Connor and I have gathered empirical evidence to support the following theory. First, persons with TBI have greater exposure to prescription opioids. Given exposure to opioids, they have greater likelihood of progression to long-term opioid use or opioid use disorder. And thirdly, if they do develop an opioid use disorder, we suspect that they may face greater challenges with successful substance use disorder treatment. So first, I'll focus on vulnerability number 1, that persons with TBI have greater exposure to prescription opioids. Acute and chronic pain are common following TBI in both civilian and military populations. One TBI model system study of adults who received inpatient rehab for a moderate or severe TBI found that the prevalence of chronic pain following TBI was estimated to be over 50% of the population. Headaches are a very common painful condition following TBI for both military and civilian populations, as well as across all TBI severities. And chronic pain following TBI is associated with both functional disability and mood disorders, which each confer their own risk for substance use problems. We know in our country that acute and chronic pain have been drivers of prescription opioid receipt in the United States, so thus we suspect that the greater prevalence of pain in this population may make people with TBI more likely to receive opioids. So during the conflicts in Iraq and Afghanistan, many military members have experienced a combat-acquired TBI. Many of these injuries have occurred during blast-related events, which may have included other traumatic experiences. And for military members who experienced a TBI while deployed, we know that TBI rarely occurs in isolation and commonly occurs in conjunction with chronic pain or post-traumatic stress disorder. The term polytrauma clinical triad was developed in the military and VA to capture this common comorbidity of TBI, PTSD, and pain. So this slide depicts findings from one of our recent papers in the Journal of Head Trauma Rehabilitation, which examined the prevalence and co-prevalence of soldiers returning from an Afghanistan or Iraq deployment who utilized services within the post-deployment year in one of the VA's polytrauma system of care, and looking at the comorbidity of these 3 conditions: chronic pain, TBI, and PTSD. And what we found was that chronic pain was the most common polytrauma condition. However, chronic pain, PTSD, and TBI were more frequently found together in isolation. So it was more likely that you had all 3 conditions than just one of them alone. And importantly, as you'll see on the right-hand side of the slide, as comorbidity increased, so did the likelihood of receiving prescription opioids in the next year in the VA. And that was true for any opioid receipt or a 30-day supply of opioids or more. There's now also emerging evidence that adults with a lifetime history of TBI are at increased risk for opioid use and misuse looking at civilian populations. So we have 2 recent papers using the Ohio State TBI identification method to assess for lifetime history of TBI. The first one was just published in Journal of Neurotrauma, led by Raj Kumar. We used the Health and Retirement Survey, which queries adults who are age 50 or older, and we assessed for lifetime history of TBI. And we found that those with a history of TBI had over 50% increased risk for using prescription opioids in the past 3 months. And they also had approximately 5 times the odds of reporting persistent pain compared to adults without TBI. We also have another paper that's under review now using the 2018 Ohio Behavioral Risk Factor Surveillance Survey. This is for our inroads study, which looks at adults age 18 and older. And our findings also suggest that adults with a history of lifetime TBI had almost 50% increased risk for reporting past year prescription opioid use and almost 80% risk for reporting misusing opioids. Now, misusing was defined as using opioids more frequently or in higher doses than prescribed by your provider, or using prescription opioids that were not prescribed to you. A study by Hammond and team found that over 70% of patients with moderate or severe TBI were prescribed opioids during their inpatient stay, and almost half were prescribed opioids during the last 2 days of their inpatient stay. So this suggests that many individuals are being discharged from inpatient rehab following TBI with opioids. And it's unclear what education they may be receiving regarding safe tapering or about understanding the risks of developing dependence when on opioids. So now I'll move on to vulnerability number 2 in the perfect storm, which is given that individuals with TBI have received prescription opioids, they may face greater likelihood of progressing to long-term opioid use or opioid use disorder. So this slide shows a analysis that we did that was published in Military Medicine, which examined active duty soldiers returning from an Afghanistan or Iraq deployment from 2008 to 2014. So this was over 500,000 soldiers. And we looked at predictors of receiving a prescription opioid in the post-deployment year in the military health system, and predictors of long-term opioid receipt, defined as over 60 days supply of opioids within a 90-day window. And what we found was that soldiers who had a TBI diagnosis were significantly more likely to receive a prescription opioid than other soldiers. So 58% of soldiers with a TBI received an opioid compared to 35% of all active duty soldiers. We also am showing here on the right-hand side a study done by VA researchers, which found that in post 9/11 veterans using the Veterans Health Administration with a TBI diagnosis, 21% filled an opioid prescription, and 25% of that group went on to use opioids long-term. Now, long-term opioid use is a risk factor for developing opioid use disorder, makes a person at greater risk for overdose. So it's an important indicator to track. Because of the increased risk of PTSD and psychological health problems among post 9/11 veterans with TBI, it's important to pay attention to the possibility that there's increased risk for concurrent benzodiazepine use and opioid use due to mental health comorbidities, which can also increase risk of overdose. Certain neurobehavioral changes may contribute to risk for substance use problems among people with TBI. For instance, cognitive deficits associated with TBI, including memory problems and executive functioning limitations, may lead to medication mismanagement or poor adherence to prescribed dosing. TBI may increase the likelihood of mood disorders, sleep disturbance, traumatic stress, all of which may be risk factors for at-risk substance use. And damage to the prefrontal cortex may also increase impulsive behavior, making it more difficult to self-regulate substance use. So for some individuals, these neurobehavioral changes may converge post-TBI to increase risk for opioid misuse or opioid use disorder. So now I'll move into the third vulnerability in the perfect storm theory. I've demonstrated that there's empirical evidence to support that persons with TBI are receiving, in general, greater exposure to prescription opioids, and given that exposure, may have greater likelihood of progression to long-term opioid use or opioid use disorder. So now I'll discuss why individuals with TBI who do develop opioid use disorder may face greater challenges with successful substance use disorder treatment.
Can I ask real quick, there's a question in the chat from Kate, what the criteria is for long-term use?
Yeah, so each study, there's different definitions used in the field. It's usually either 90 days supply within a year. It's usually a 60 or 90 day supply within a certain time frame. Sometimes it's 90 days within a 90 day supply within 180 days. It varies, but it's usually about 90 days supply. Feel free to jump in again. I can't see anyone, so I'm just.
No, I'm looking in the chat.
Okay. Thank you. Okay. There are several reasons why persons with TBI may face additional challenges accessing and engaging in substance use disorder treatment. And these are not necessarily specific to opioid use disorder treatment, just substance use disorder treatment in general. Neurobehavioral impairments may undermine the ability to participate in treatment in the traditional ways. Damage to the frontal lobe of the brain affects thoughts, feelings, and behaviors, promoting disinhibition. Cognitive impairments may affect a person's communication or learning style, making participation in didactic training and group interventions that are common in substance use disorder treatment difficult. It can be easy for substance use treatment providers to see this behavior as intentionally disruptive or resistant to treatment, particularly when there are no visible signs of disability and the provider hasn't screened for TBI. All of this may undermine the treatment relationship. As we already discussed, persons with TBI, especially those with substance use disorder, may have comorbid psychiatric conditions, which further complicates substance use disorder treatment. And individuals with TBI may also have less ability to sustain improvements without external structure supports, which is important to sustain recovery for substance use disorder, which is a chronic relapsing condition. In a study by Fonda et al. In Journal of Head Trauma Rehabilitation of post 9/11 veterans using the Veterans Health Administration, they were looking at veterans receiving long-term opioid therapy for chronic non-cancer pain. And they found that veterans with TBI had more than a 3-fold increase in opioid overdose compared to those without a TBI. And this was slightly attenuated in mediation analyses for co-occurring psychiatric conditions, but remained significant. So those with TBI were at increased risk for non-fatal opioid overdose. There's also been multiple studies now showing that TBI is associated with increased risk for overdose deaths. The study on the left, which used data from the TBI model system study, identified cause of death on death certificates and found that after surviving a moderate or severe TBI and receiving inpatient rehabilitation services, persons with TBI were more than 11 times more likely to die from an accidental drug poisoning than individuals without TBI. Most of these poisonings were drug-related, and 2/3 included an opioid. On the right, there was a study done by Byers et al. In brain injury in 2019, which reported that among veterans using the Veterans Health Administration, individuals with TBI were at increased risk of death by drug overdose. This was not specific to opioids. And mortality rates for death by drug overdose were consistently higher for veterans with mild or moderate or severe TBI compared to those without TBI, even after controlling for psychiatric conditions. So So several studies with both civilian and military veteran populations have found an association between TBI and increased risk for death by suicide. We also know that long-term opioid therapy and opioid use disorder also increases risk for suicide. One VHA study found that among veterans prescribed long-term opioid therapy to treat chronic pain, individuals with TBI were at increased risk for suicide attempt compared to those without a TBI. So in summary, emerging empirical studies have demonstrated that persons with TBI are getting more exposure to opioids than people without. And given this exposure, they are at increased risk for advancing to long-term opioid therapy or addiction, and may face greater challenges successfully navigating through substance use disorder treatment. This cycle may be more complex than with other substances due to the highly addictive nature of opioids. And the consequences of this perfect storm may be devastating, and more research is needed to identify non-pharmacological approaches to treating pain among individuals with TBI, and to determine the role of opioid use in risk for death by suicide following TBI. And more research is needed to understand this cycle. I will mention briefly that so far we've been talking about how TBI may be a risk factor for opioid use and adverse consequences, but there is acknowledgement that opioid overdose may actually lead to future brain injury. During an overdose, respiration is suppressed or stopped, denying oxygen to the brain, and this can lead to anoxic brain damage if completely denied, or hypoxic damage if reduced. And similar to TBI, anoxic or hypoxic damage may inhibit executive functioning and self-regulation, further increasing risk for ongoing opioid use disorder. And also overdose, when an overdose occurs, an individual may fall, increasing risk for additional TBI. So just very briefly, some recommendations for substance use treatment providers include screening for lifetime history of TBI, identifying and accommodating neurobehavioral deficits, considering and addressing important comorbidities, creating formal and/or informal supports needed during and after treatment completion, and medication-based treatments such as buprenorphine or methadone are safe and effective and can be used with other methods to reduce cue sensitivity. So we always like to acknowledge in our work at Brandeis, and we do a lot of substance use research, that was, as with other chronic diseases, opioid use disorder, substance use disorder may be a lifelong process, but recovery is possible. And many people do recover from opioid use disorder and live successful lives as they define it. And we want to encourage this process of change and ability to direct one's own life to one's own full potential. So next I'm going to transition into this potential intersection with intimate partner violence. But before I do that, it might be a good time for me to just pause for a minute and see if anyone has any questions about what I presented so far. And if not, I can just keep going. I have a couple more slides.
If there are any questions, you can unmic. Rachel, it's so important what you are presenting right now. I just want to thank you for all the work that you're doing. This is really important stuff. Are there any questions? I don't have the view to see everybody. Hold on.
Rachel, this is the other Rachel. I just want to wait and hear your next, because I have some thoughts, but I want to hear what you say next. So is that okay?
Okay. Yeah, why don't I keep going? Great. Okay, so, all right. So next I want us, I see this as a group activity, but I'll get us started in the first couple slides, and then I'm looking forward to the discussion. So ever since I've been tracking the really strong and important research that's been coming out the past several years on how largely women are experiencing TBI resulting from intimate partner violence and all the great work that's being done in that space. I've been thinking about, as a substance use researcher, how substance use might play a role in that dynamic or be something important to think about when thinking about those relationships. So just to start us off, as this group knows very well, there's been a lot of great research demonstrating that women who experience IPV are at increased risk for TBI. And my talk today has shown that persons who've experienced a TBI are at increased risk for at-risk substance use. However, I think that the relationship between these three health risks are more complex than this initial figure. So I also note that there are decades of research demonstrating that women who experience IPV are at increased risk for at-risk substance use. Now, I worked last year at Brandeis, had an undergraduate student, Maddie Pliskin, who worked with me on our Inroads project looking at substance use following TBI. I know she presented to this group recently and has been working with Dr. Valera as well. I mean, I had her work with me on a lit review on substance use following intimate partner violence, and learned that there is a lot of really strong and great work in this area for a long time. And that, for example, even recently, there was a systematic review by Stone and Emily Rothman on opioid use and intimate partner violence that found that opioid use is elevated among people with a history of IPV or perpetrators of IPV, and intimate partner violence is frequent among people who use opioids. I think less is known about opioids and other drugs in terms of this relationship, but evidence seems rather strong for risk for alcohol use problems following intimate partner violence. We also see in this figure that substance use is a risk factor for future TBI. So we know that many individuals, at least a third to half, are using substances or intoxicated at the time of their TBI. And that following TBI, because risk is increased for substance use after injury, that increases risk for future traumatic brain injury. And then lastly, substance use disorder can increase risk for sexual violence or trauma, particularly among women. So my last slide is just to sort of put out there some things I've been thinking about where I think it would be important for future research in this area. Are women who experience a TBI stemming from intimate partner violence at even greater risk for at-risk substance use compared to women with a TBI alone or who's experienced intimate partner violence alone? There's not been much work done in this area, the intersection of the three conditions. There was one study by St. Ivany et al. In 2018 where they conducted interviews with women who reported a TBI from being hit on the head during intimate partner violence. And women reported using drugs or alcohol to deal with ongoing chronic pain or to escape. Another question is, what is the role of substance use during IPV episodes by the perpetrator or person experiencing IPV? Prior studies have suggested that substance use can exacerbate or precipitate violence. Does substance use following intimate partner violence increase risk for future brain injuries? I would suspect it does, but I don't think that's been studied. At least I don't know of anything. Are there specific considerations for substance use treatment providers when working with clients who have a history of both TBI and intimate partner violence? I know trauma-informed care is very important. One study by Lipsky et al. In 2009 found that 2/3 of women in substance use treatment programs reported intimate partner violence just in the past year, and intimate partner violence negatively impacted substance use treatment outcomes. So it impeded the success of substance use treatment. And then lastly, are individuals who experience TBI, IPV, and at-risk substance use at heightened risk for other adverse outcomes, like the outcomes I talked about today in the perfect storm theory, and how can we think more about that? And then I'll just, I would love to hear other ideas too. So I suspect you all have some thoughts on this. I'll stop there.
Thank you for such an important talk. This topic is one that I really wanted to have on for a long time. And I think that the overshadowing all of this is the first time in history that women are drinking as much alcohol as men. And I think that's going to change a lot of the overall TBI numbers. I mean, there's been a specific campaign by alcohol companies to reach new groups of women that didn't drink before or increase the amount that they're drinking. So I think it's really important to study this overall from a context of women's health, but especially with the TBI and the subset of domestic violence. So we're going to invite people to it's a small enough group to unmic and ask questions or just put their thoughts out there. Or if anybody has incorporated some question about substance use in their own work or thinking about their own research, we could also brainstorm on that. Hi, Paul.
Hi there. Thanks. Thanks for a great talk, Rachel. It's really interesting, and I think it's a really important thing to consider, the intersection of all these factors. So in our work, it kind of mirrors what Eve has done in the past, which is to incorporate various assessments of substance use, more from a control perspective, like to control for the effects of potential substance use or history of substance use over a period of time, and how that might have some impact on various measures of brain function. So it's definitely obviously a very important consideration for many of the reasons that you suggested. And I think as we start to think more about potential treatments, that taking it into account as one factor that should be a target of interventions, I think it is also really important to consider. So yes, please keep doing the great work and incorporate intimate partner violence as part of the questions you and your team are addressing. I think it's really a nice approach. I get one factor or work that I wanted to kind of raise was the work on people who are experiencing homelessness or are otherwise vulnerably housed. So that's another intersection where there's elements of substance use disorder, mental health issues, intimate partner violence, and homelessness comes along with that. And so there are a number of studies in North America that are looking at that. There's one called the Hotel Study that's takes place in the downtown east side of Vancouver, which is the highest proportion of homelessness in Canada. And so it's a remarkable study that's been going on for 10 years now, and they absolutely obviously incorporate substance use disorder as part of the things that they're measuring and trying to account for, and some of the things you're looking at. So not really a question, just more a comment and then supportive support for this approach. Sure. Thank you.
Yeah, thank you, Paul. I mean, I suspect, I don't want to overstate that no other studies aren't thinking about the three, but I think what you're saying is probably right, that maybe substance use information is being gathered, either to control for it, or a lot of studies exclude people with substance use disorder. But I think it's more important to think about it more directly in future work, and just draw more attention to it and see that I think it can really impede rehabilitation of, so it's a good point. And I suspect that people who are doing research have data on it and haven't focused on it yet. Or there's more opportunity from data that's already been collected.
Well, Rachel, thank you very much. And I think a couple of pieces coming from kind of the direct practice side of things, substance use and survivors who are using substances is by far, I would say, one of the most consistent challenges and the hardest thing for us to figure out how to effectively work with, manage, kind of help people get what they need out of our DV services. And has been in most EV programs. And it's one of those things that we feel like, if we were to ask many DV staff program, particularly people who work in residential programs, what they like to help with and what they like to know how to do better, it's really working with people who are also struggling with substance use. But I did want to bring up, because we actually, a couple of years ago, we had a project with Ohio State around, and it was an opioid. We did focus groups with program staff, and did some individual interviews with survivors accessing DV programs, kind of around substance use. And I think that, another piece that is coming through really, really clear is the role of substance use coercion, which is when just kind of like very intentional ways in which abusers get people addicted to substances.
You're breaking up, Rachel.
Oh, sorry. I can't do anything about, can you hear me now? Am I okay? Sorry. Don't you love it how like, you're like, I don't know why I'm just sitting here in my room talking.
Everyone listen.
But, kind of very intentionally sabotage recovery, threaten people around issues of substance use, use that as a way to keep people from feeling like they could call the cops. And if I can real quick, this is a little preview for you all who want to join me tomorrow. This is something we're going to be talking about. If you all can share, can see our screen. This is from, I think there were 52 in our sample of DV survivors who actually did a telephone interview with us. And we asked around things like, has your partner ever made you use alcohol or drugs, or made you use more than you wanted? Have they ever threatened to harm you in order to get you to use alcohol or other drugs? Have they ever tried to control your access? Have you ever been afraid to call the police? You see 46% said they ever tried to manipulate you by making you go into withdrawal. Have ever stopped you from cutting down or quitting alcohol or other drugs when you wanted to? So I think that that's the other thing, just the very active role that abusers can play in substance use initiation, in people who are trying to access treatment, and kind of what that is. So I think that that's another, I'm sorry, it's summer. That is my son's best friend out there. It is 65 degrees in Ohio, so boys don't wear shirts once it's 65 degrees in Ohio in the spring. But I mean, I just think that this is just a whole another piece when we see, again, not just how survivors get involved with substance use, and then when they're trying to get help for substance use, just kind of the role in which abusers can play in kind of making that not happen. So that's something that we've been thinking about a lot. And I know that our Ohio State colleagues are working on a paper kind of more specifically looking at this whole substance use coercion piece. So if this wasn't complicated enough, just wanted to throw that piece in there too. And I think that sometimes there is this whole like, issue around, survivors are picking their substances over their kids, or picking their, and just how complicated that is. So that just is an additional comment that I think, we can do some of this trauma-informed. I think trauma-informed treatment is really important. I think figuring out how to kind of adjust what we normally do, or when we're adding in all of these variables, like whatever normal substance use treatment is, plus trauma, plus brain injury, plus DV. But I also think that really just recognizing that sometimes some of those, like recovery, there might be somebody very actively working against someone being in recovery and completing treatment and doing all of that. I think that the last piece that we also have found that has happened pretty consistently among survivors who have been using substances is just that that has become, so once they stop using their substances, a lot of the trauma stuff comes back pretty deep and pretty intense and pretty hard. So they're not able to sleep anymore because they're having nightmares. They're not able to, kind of having flashbacks, kind of that kind of piece. So if that's not all kind of understood together, I think that's another reason that can just make it really hard. So, I've talked to many survivors who have just been like this is the only way I can function, and it's what keeps the trauma stuff just kind of at bay. So I don't know if that answered anything, but I just think that it's a lot. So if you could figure this out, please, we'd really appreciate that. Um, we need it like yesterday. But thank you for continuing to work on that and think about that.
Yeah. I think the field would benefit from people with different expertise kind of getting together and thinking this through more, because it's challenging from a temporal framework, thinking about like what came first, what to look at, doesn't matter what came first, or, you know, or if you're just focusing on treatment and how to help someone who has these 3 histories, you know. But yeah, thanks for sharing all that. That's great.
And I just wanted to share one thing, just to take it out of the context of all of these things. And I'm trying to do my slide at the same time. When I was diagnosed with breast cancer in 2013, I went and got a pain med doctor to be my doctor because my gut was, would I to be put on opiates? I just knew there was enough trouble, and had my own pain doctor. But this study came out in December that researchers homed in on how many women, so these are women with breast cancer, how many women without prior persistent drug use became chronic users after surgery. And it was 13% of women who had not been previously opioid users developed a dependent on opiates and filling opiates twice during the 90-day to 1-year period during the post-op. So we've got a substance that's in a situation like breast cancer. You know, we're not looking at trauma, we're not looking at domestic violence, we're not looking at TBI, just women with breast cancer. You get 13% addicted there from, you know, this procedure. And then you pile on these other factors. I just think that the opiate crisis, you know, has compelled so many different issues, you know, into the red zone. So I really appreciate that, you know, looking at opiates, you know, in addition to alcohol. Any other thoughts? I'm looking at the chat. Oh, and then the study about women and alcohol was the Harvard's Women's Health Study that I mentioned about women for the first time drinking versus men. Kate Monahan had to go to the other meeting. Thank you for your work, Rachel. And I talked to Kristen Dams-O'Connor. She's also in the other meeting, the National Academy's meeting today. And so that's where a lot of people are, but they're texting in and said they'll watch the video.
Yeah, so Kristen's been integral to thinking through this, working on the perfect storm work with John, Corrigan, and I. And I chose today to focus on that mostly, rather, but prior to that, my work was mostly on alcohol. And I think that is where most of the evidence and the studies with looking at risk for substance use following TBI has been focused on alcohol. We know a lot more about that. But I think both are really important and probably more related than we think, you know, overlapping use.
Last 2 years ago, I spoke at the West Virginia State Conference, TBI conference, and West Virginia has had a horrific time with opiates. And their discussion of TBI and opiate use, you know, I think depending on where on the corridor of 95 too, that you can, through these communities that have just been wiped out by opiates. Anyone else have any thoughts? Tori, Jamie?
Hey, Rachel, this is Kate. I loved hearing what you're up to and where you're hoping to go, or where I know you will go with your research. And I was wondering your thoughts about how, if at all, you'll incorporate PTSD and, you know, just so much overlap. Well, when you're talking about women who've had IPV experiences, there's going to be a lot of PTSD. And then the overlap and comorbidity with substance use disorders and risk for TBI. It's really messy. I don't have any good answers, but I was curious about.
Yeah, it's like, Yeah, I mean, I find it's I thought of it after the fact, but how the DoD and VA has came up with this term, the trauma clinical triad, about TBI and
Mhm.
PTSD and chronic pain, to acknowledge that these three conditions are often present together and may have a variety of, increased risk associated with that. And I think that, um, you know, I don't think there's reason to think that's not there with women who've had intimate partner violence. I mean, there's probably maybe some more digging into pain, but we've already seen from other studies that following TBI, people in generally have risk for greater pain.
Mhm.
So I think that you can't ignore PTSD and other mental health conditions in this intersection that I was raising today. And I think that um, that is the challenge of how to think about whether you're focusing on studies looking at long-term outcomes, how to like understand how these things are related to each other, and how to try to distill an independent effect of one thing, or is it really in
Mhm.
collaboration
Synergy of.
together versus yeah, versus like research that's really focused in on treatment and how to improve outcomes for people with a
Mhm.
variety of these different complexities. And then that's a whole different line of important work. So I collaborate with a lot of mostly psychologists. I'm not a psychologist, but who help me think about PTSD and mental health conditions. But I'm wondering, Kate, where you think the field is going with. I know that there's so much work ongoing looking at TBI um, stemming from intimate partner violence, and just um, how you see maybe substance use fitting into that, or
Such a great
PTSD
question. I'm curious
yourself.
too. Oh, sorry. Didn't mean to talk over you. I'm hoping others will jump in too. Um, on this issue, but this related to a comment Paul made earlier about the tendency for descriptive studies to kind of maybe control for something rather than study it explicitly. And I think in the TBI literature, as it applies to IPV, I think there's been a lot of neglect of PTSD, and that we need to be studying it more overtly in this population. And I think if we start looking at substance use more fully in these studies too, we're going to find a lot of it. Tara Golovsky and I presented some data. I don't know if we presented the data, but we have some data. We were kind of shocked how much substance use was going on in our sample of about 50 women who had probable or full PTSD. These were all IPV survivors. So there's just so much complexity. And so we need kind of larger samples to be able to study all these factors more comprehensively. What do others think?
I had a question, Rachel. The Venn diagram, that was men and women together, or that was mostly male? I wondered if it was men and women together, if it was separated by gender, would those proportions change at all?
Maybe that was a largely male sample. So women were included, but they were probably 5 to 7% of that
Which would make
sample.
sense with most of the military studies. It's always, under 10.
Yeah,
But it would be
we do
interesting.
see sorry, go ahead.
It'd just be interesting to see if any of those, I love Venn diagrams. I just find them fascinating, but it would be interesting to see if any of those panels changed if you were looking at, military sexual trauma, because I know that that's a lot of the polytrauma that they're dealing with females. The TBI is polytrauma, military sexual.
Yeah, it's
And
hard
you
to
have the PTSD
capture.
in that piece.
Yeah, it's hard to capture military sexual trauma in the military. So most of my work is with DoD data, and I know the VA does great screening data for MST once veterans get to the VA. but it's tricky to pick it up while they're in the DOD in an identified way. But we do have information about, like, soldiers complete a post-deployment health assessment survey when they get back. And we noticed that one of our papers that women were reporting just as high rates of being wounded, injured, assaulted, or hurt on the previous deployment as men. And it doesn't quite make sense because they weren't in the same combat roles. They weren't, they had occupations that weren't engaged in combat as much. So we speculated that that could be picking up military sexual trauma. But I think that, yeah, so I think you're right. I think that looking at it just in general, like the field of TBI, importantly drawing more focus, like your recent paper that you were on, Catherine, you know, that more TBI research needs to be paying attention to gender and sex-based differences. And this is another area where that's important, specifically for substance use. A lot of substance use work has just lumped everybody together.
Any other
But
thoughts?
I think, one more thing, Kate, that we know PTSD increases risk for unhealthy substance use. So there's, you know, anytime when you add these different risk factors, the risk for increased substance use is getting very high.
Well, it's really, really super important work. Anyone else like to make a comment? Jonathan, there from Arizona. Johnny,
A little bit of a comment, less of a question, but I just, first of all, Rachel, thank you so much. I think it really highlights this like multimodal approach that we need to support these women. I know, particularly in Southern Ontario, we have more of this like siloed approach to intervention and treatment, and these women are having to go to so many different resources to get the help they need. And I think just like recognizing that all of this does kind of work together and intercepts at every point, and just ensuring that whatever we're doing, the hope is to get like the intervention to these women so that they're like getting the help they need.
and I think your message is really important, that there is hope. There are treatments. And I think finally 12-step programs, AA is starting to understand the importance of Suboxone. And there's a push within the 12-step movement that your medications that you're on need to be prescribed by a doctor and not by a 12-step group. And I think for a long time that was the access that people were, you know, people with on Suboxone were having a really hard time trying to find 12-step groups that were safe. So I hope that that will bring in more people into 12-step recovery, that Suboxone is for them the right way to go. So I hope about that. Well, thank you so much, Rachel. Again, it was nice to actually have a small enough group to have a conversation. I will put the recording up and send it to everybody, and just really, really important work. And I appreciate your time.
Thank you. Yeah, people should feel free to get in touch if you have, you know, data or thoughts about this in the future and you want to collaborate, or I'd love to be involved. So think this through. It's not, it's an area I remain really interested in, but I have so many things up in the air that it's not something I've been able to actually study. So.
Well, I think with COVID and, you know, a sudden awareness of the global nature of domestic violence, IPV, you know, and not associated with just one person or one incident here or there. I think globally there's a more of an awareness. So hopefully funding will come through in the post-COVID world to really look at this, because I think everybody, you know, has a new awareness. So thank you for your time today. Thank you everybody for coming. And we'll either see you Thursday for the casual conversation with Ron Savage, or at the end of the month with our next task force. Thanks everybody, and stay safe. Take care.
Bye. Thank you so much.